Welcome back, everyone. If you're currently drowning in RCOG Green-top Guidelines and kind of stressing out over those tricky oscillotropes, take a deep breath. We've got you. Today, we're diving into a super high-yield, exam-focused review of Guideline number 71. This is the management of inherited bleeding disorders in pregnancy. For all you MRCOG candidates out there, this explainer is literally going to be your best friend. We're going to distill down the essential guidelines, the exact timelines, and those hard numbers you absolutely have to commit to memory. Basically, everything you need to safely manage these high-risk pregnancies and absolutely crush those stations. All right, let's jump right in. Here's our roadmap for today. We're following the actual clinical pathway step by step, starting with definitions and risk, then moving through antenatal care, intrapartum management, postpartum prevention, and finally wrapping up with neonatal diagnostics. Okay, part 1, definitions and risk stratification. Let's get our terms straight before the patient even conceives. So, we have to start with hemophilia. Now, you already know this is an X-linked condition with reduced or absent clotting factor, 8, that's Haemophilia A, or factor 9, which is Haemophilia B. But here is a massive exam pitfall. Do not just assume you'll see a clear family tree. The guidelines explicitly point out that up to 50% of neonatal males with severe hemophilia have absolutely zero prior family history, none. In those cases, there's a 90% chance the mother is a carrier due to a spontaneous mutation. So, having a high index of clinical suspicion and relying on accurate genetic testing, absolutely crucial. Now, maternal bleeding risk directly dictates your entire game plan. Take a close look at the high-risk category here. We're talking type 3 von Willebrand disease, severe rare coagulopathies, severe platelet function disorders, and symptomatic hemophilia carriers. These patients need adequate replacement therapy, and here's the kicker, given after the onset of established labor. Now, contrast that with the mild risk group, like type 1 VW, where their VWF activity has actually corrected to over 0.5 international units per mil during pregnancy. For them, we can usually manage with just tranexamic acid. So you see, knowing exactly where your patient sits on the stratification is a real game changer for your delivery strategy. Moving right along to Section 2, pre-pregnancy and antenatal care. Okay, if there is one absolutely non-negotiable point for your exam, and honestly, for safe clinical practice, it's that every single antenatal step requires a multidisciplinary team. An MDT approach is essential. You simply cannot manage these women solo. It takes seamless coordination between expert obstetricians, hematologists, and anesthesiologists. And one of the very first things this dream team must do, check the maternal baseline factor 8 or IX levels right at booking. You have to get this baseline before you even think about considering any antenatal procedures. This brings us to the prenatal diagnosis timeline. Because hemophilia is X-linked, doing non-invasive cell-free fetal DNA testing for sex determination at 9 weeks is, well, it's incredible. It spreads like wildfire how useful this is. If the maternal blood tells us the fetus is female, we can dramatically scale back our risk protocols for the baby. But if it's male, we then offer invasive testing. That means chorionic villus sampling between 11 and 14 weeks or amniocentesis after 15 weeks to check for the specific familial mutation. All right, everyone, I need you to burn this golden number into your memory right now, 0.5 international units per milliliter. This is the absolute minimum factor 8, factor 9, or VWF rostacetin cofactor level required to safely cover any invasive procedure. That includes the CVS or amniocentesis we were just talking about, or even safely managing a spontaneous miscarriage. If your patient's levels dip below this magic number, they require hemostatic support, like DDAVP or factor concentrates, before you go anywhere near them with a needle. Shifting gears to Section 3, intrapartum and delivery management. Let's head into the delivery room. When you're delivering a male fetus at risk of hemophilia, the number one goal is protecting against devastating iatrogenic intracranial hemorrhage. So, what's safe? Normal vaginal delivery is safe. A cesarean section is safe if it's obstetrically indicated, but we really need to focus on the absolute don'ts. You must avoid ventouse delivery completely. Avoid mid-cavity forceps. And those invasive monitoring tools, like fetal scalp electrodes and fetal blood sampling, they are strictly 100% contraindicated in babies expected to have severe or moderate hemophilia, no exceptions. Let's talk pain management. Regional anesthesia, like an epidural, is obviously fantastic, but you need secure factor 8 or 9 levels of greater than 0.5 international units per mil to avoid spinal hematomas. It's generally safe in type 1 VW, assuming their levels have physiologically normalized during the pregnancy. But wait, here's a massive safety point for your OSCEs. Central neuroaxial anesthesia must be completely and strictly avoided in women with Bernard-Soulier syndrome. Even if you pump them full of platelet transfusions, their individual response is just way too unpredictable, and there's a huge risk of platelet refractoriness. Bottom line, do not risk an epidural in Bernard-Soulier. We're in the home stretch. Section 4, postpartum hemorrhage prevention. The baby is out, but our job isn't done. Let's walk through this exact step-by-step timeline for postpartum care. Step 1, active management of the third stage. Highly, highly recommended for all these women. Step 2, you absolutely must maintain those target factor levels above 0.5. And step 3, this is where the time frame difference is critical. You have to maintain these levels for at least 3 days following an uncomplicated vaginal delivery. But you extend that to 5 days following an instrumental delivery or a Caesarean section simply because of the increased tissue trauma. 3 days versus 5 days. Make sure you've got that down. Now, I want to highlight a very specific, kind of fascinating physiological quirk straight from the guideline. There's an increased risk of postpartum hemorrhage in factor XI deficient women, but it is highest in those who not only have a clinical bleeding phenotype, but are also of blood group O. I mean, this is exactly the type of nuanced, hyper-specific detail examiners just love to test to see if you really know your stuff. Also, if you ever encounter a patient with Glanzmann's thrombasthenia, or GT, you need to be on high alert. GT carries a really severe risk of both intrapartum and postpartum hemorrhage. For these women, we must proactively use prophylactic platelet transfusions at delivery, and crucially, these platelets should be HLA matched whenever possible to prevent alloimmunization. Oh, and this should always, always be done in combination with tranexamic acid. Finally, Section 5, neonatal diagnostic management. What do we do with the newborn? Checking out the guidelines for neonatal testing, our schedule for the baby depends entirely on the severity of the condition. For severe deficiencies, like severe Haemophilia A or B, we need immediate cord blood testing for factor assays. But take a look at the mild deficiencies. Normal-term neonates naturally have physiologically altered factor levels right at birth. So diagnosing a mild deficiency often means we have to wait 3 to 6 months to retest the infant. We do this to avoid making false diagnoses based on those natural temporary neonatal variations. Now, while we're waiting on those cord blood factor assays, our standard neonatal protocols have to be adjusted. Yes, the neonate absolutely needs vitamin K, but you must administer oral vitamin K. You have to strictly avoid all intramuscular injections. That includes the standard IM vitamin K and any immunizations until the newborn's coagulation results are confirmed to be completely normal. Think about it. A routine IM injection in an undiagnosed severe hemophiliac, it could cause a massive limb-threatening muscle bleed. Just don't do it. Wow, okay, we have covered a massive amount of high-yield ground today, from those 9-week cfDNA timelines to maintaining that golden 0.5 threshold and adjusting delivery methods to protect the neonate. As you prep for your MRCOG exams and head back into clinical practice, I want to leave you with this final provocative thought. Knowing the theory is one thing, right? But how will you integrate this complex multidisciplinary framework to actually secure these strict factor thresholds and ensure seamless communication in your own busy local delivery suite? Thank you so much for exploring this explainer with me today, and best of luck putting this vital knowledge into practice.